Hello again, this is Dr. Wu. I'm Dr. Wu, and our show is America's Healthcare Crisis. This is our 42nd show. The title of our program tonight is The Quality Issue in Dermatology, Part 2. And I'd like to invite our speakers back to continue on what we left off the last segment. You mentioning acne?
Yes.
Okay.
Well, acne is probably the most common skin disorder that I saw in my 30-some-odd years of practice. To many, it's a disease that they like to trivialize. The mother will look at the youngster with a couple of blemishes on his or her face and say, oh, go off to the drugstore and get a tube of something and try to deal with it this way. Acne is absolutely devastating to a teenager. And there's tremendous variation in their response to it. You can see a young man with terrible cystic acne all over his face, and he barely bats an eye. Then you'll see a young lady of 14 who has a tiny little pimple at the end of her nose, and she thinks the world has come to an end. So there's a tremendous challenge in treating acne and in trying to learn about the youngster. And one of the delights of practice for me was treating acne. I thoroughly enjoyed young people. They're great to deal with. Many times once you get the parent out of the picture after the first couple of visits, you develop a nice relationship, a rapport with these people, and you see them through their illness. And they're generally pretty good about following treatment. One of the big problems you encounter in any medical practice is whether or not the patient is going to follow through with treatment, pay attention, and do what's appropriate for their cure, if you would. Kids are generally pretty good about following through, and they are tremendously grateful when their disorder is brought under control. Acne affects probably 98% of teenagers have acne, since we call it acne, whether it varies from a very mild problem to a very severe problem. And quite honestly, most of them don't need a whole lot of help. Most of them can handle it with some drugstore medications and some common sense in terms of skin care. But those that are in serious trouble with it truly warrant a tremendous amount of energy and time and effort upon the part of the physician to bring it under control.
Education, patient education, and
patient education
support
is a tremendous part of it, and then the ongoing support that goes along with that.
Let me ask you something from the standpoint of a primary care doc. What are the, obviously, misdiagnosed skin cancers can be very serious problem if you wait too long to refer. But the other problems, what are the downsides if you misdiagnose for a week or two? Are you to really seriously harm the patients in any way for skin conditions?
Well, if you're talking about
except for the inconvenience and the nuisance and unhappiness.
I think if you're talking about a week or two, probably not. Now, if you're looking at somebody who has, for instance, a staphylococcal infection of their skin, and this is looked at and the diagnosis is missed, and say a cortisone cream is applied early on. And this can sometimes occur particularly in infants and young children where these diseases will not behave in an adult-like fashion. They will blister on the skin and for all the world may look like a reaction of allergy of some sort or a bug bite. And then you can apply cortisone, and within a day or two or a week's time, this youngster may have impetigo, the old term for it, a bacterial infection of the skin over a very widespread area of the body. So there is some immediacy to the diagnosis. If somebody has psoriasis, which is a long-term and chronic, oftentimes lifelong disease, and somebody doesn't make the diagnosis for the first month or 2 or 6 months in terms of, is this a serious thing for the patient's well-being? No, I'd have to say that it's not. Is it an inconvenience? Sure, as you mentioned, because what would be perhaps most effective, appropriate treatment might have been deferred for that period of time. So it's not at the end of the world for it, but
it would be how many cases of acute serious staph infection with systemic manifestations that were missed in your experience?
I'm not quite sure I understand your question.
You say that if a patient has a significant staphylococcal dermatitis and was given cortisone cream and became a more significant serious infection, did you see a lot of that? Because I haven't had one single case that I would have done that.
I've seen it over the years a number of times. I can't quote your figure. Sure, you see this happen.
Really?
And there's some other conditions too. Probably one that stands out is herpes zoster or shingles.
Sure.
In that if the diagnosis is made early, you can intervene and shorten the course dramatically, and more importantly, prevent post-herpetic neuralgia, this ongoing pain, this ghost-like pain that goes on for months and months and months.
Yeah.
And so certainly that's one. And I've seen several cases of different forms of lupus that have been misdiagnosed and serious consequences develop because of the delay in diagnosis.
Yeah.
And there's a number of scarring conditions that, if misdiagnosed, the scarring process continues, like discoid lupus and a number of other conditions, so that often the patient's left with some disfiguring scars that were basically unnecessary. I mean,
so you advise us to give a shot for maybe 2-3 weeks and then refer as a general guideline?
I wouldn't offer a guideline. I think you have to, let your own conscience be your guide in any primary care physician, because obviously primary care physicians are very good and they're very capable, and I don't in any way mean to be critical of their abilities to diagnose skin disorders. I think you have to look at it from the standpoint of how well trained am I in diseases of the skin, how many cases of this or that have I seen, how comfortable am I in looking at it and saying, I know what this is. We as specialists make referrals all the time. If you look at something, you say, gee, I'm just not quite sure if I'm approaching this correctly. Am I absolutely certain of my diagnosis? Am I carrying out the most effective treatment for this individual? And if you can clearly look in the mirror and say, gosh, I sure am, then you're satisfied you're doing the best job. If there's any uncertainty whatsoever, then the specialist will make the referral. Because here again, it's the two heads are better than one. Many times I might send somebody to Jim and he will look at it and say, hey, I agree with your diagnosis, but have you thought about this different wrinkle in treatment? And I say, boy, no, I hadn't, thank you. And then you pass this along to the patient. Dermatologists are famous for gathering in masses at skin meetings and bringing interesting patients in. We might have 15 patients and 150 doctors looking at them, and then we will send the patients on their way and go in and discuss those difficult cases amongst that mass of people. And out of that, you may come up with somebody that saw 2 or 3 or 4 cases like that over the course of the years that he's practiced. And you can say, hey, have you thought about this? And you'll say, no, I really hadn't. And then this diagnosis is considered. So referral should be made by any physician, any specialty, with any disease, if you're uncertain of what it is or how to best deal with it, because the outcome that we're all looking for is effective treatment that is going to, if not cure, at least control the process, and try to do it at a cost that doesn't break the bank, and try to end up with a patient that's satisfied. There's nothing more satisfying to a doctor than to have a patient who is satisfied.
In my experience as a primary care doc, I think the most frustrating, difficult situations that I have encountered in dermatology are the people who are worried about nothingness. I mean, like, a little hypopigmented, spot on the face, especially things on their face, because they have some kind of a hang-up, psychological hang-up about it. And no matter what you do, they're unhappy, because they're basically unhappy, not because of that problem of what you do. Do you have any advice on that? I'm talking about the people who really have something that manifests as a skin situation because they see it, be it a little more here or there, but it really is not their problem. The problem is something else inside, the psychodynamic or the frustration or whatever that you cannot have the answer for.
Well, I think sometimes people will present with what you and I might look at as trivial, because we've seen it so many times, or we've seen it on ourselves or a family member or what have you, and they're terrified. Terrified because the minute they see something appear on the skin, they think the worst, that it's a skin cancer. And they hear so much about skin cancer, and they have this mistaken perception that if I have a skin cancer and it's not taken care of within a day or two, or that somehow this is going to have a fateful outcome for them, which is in fact seldom the case. People like that, frequently with nothing more than reassurance, will be satisfied about the benign nature of their problem, and they'll go away satisfied. Others will be insistent to the point, well, are you really sure, doctor? And
Yeah.
many times you will end up removing the lesion to have it microscopically checked, because the naked eye is pretty good most of the time, but sometimes without the microscopic reassurance you can't be absolutely certain. Other times it's obvious that this is an external manifestation of some sort of internal anxiety or what have you.
Right.
And this you don't learn at first blush. This requires some time with the patient and perhaps repeated visits to get to know his or her personality. And perhaps this is where the primary care physician can play a very important role, because the primary care doctor sees people over the long haul, in and out of many illnesses and situations and so forth. Dermatologists tend to see people in short bursts for a disorder that comes, it's diagnosed, it's treated, and then you may not see them again for 6 or 8 years.
Yeah.
So it's, yes, we can certainly tune into and recognize overt external manifestations where they're dwelling on something that is trivial, where they're really kind of call your attention to something much more meaningful within their life or lifestyle and so forth.
Because it seems to me like the psychodynamics of skin conditions, in my experience, have been very pronounced. In other words, a lot of hives and itching are stress related, and because the causes of stress can be so numerous, it takes a tremendous amount of time and patience to get to know the patients. But usually their feeling is that if you're going to give them a quick answer, then they're going to go to see the specialist. You know what I'm saying? In other words, it's not because of a lack of knowledge, because they just don't have answers for them. They immediately feel that they should be referred, or having more quick fixes, what do you call it? A lot of situations that, I mean, we live in a polluted environment, and I see a lot of patients who react to different conditions who have to do with hygiene. And what do you tell them? Do you tell them to modify their lifestyle? How do you subtly suggest to them that it has nothing to do with a medical pathology? It has something to do with their way of living.
Well, I think it's here a matter of getting to know the patient, trying to get up inside their head, so to speak, and try to ferret out what is underlying their concern. I certainly have no qualms, haven't had over the years, in making suggestions to patients where it's obvious to me that their lifestyle is having a significant impact on their disease. We'll see a disorder very much like psoriasis. It's called intertrigo. It has the look and appearance of psoriasis in areas of skin beneath the arms, in the navel, beneath the breasts in women. And we'll see it more so in people who are obese, beyond just being a little plump or pudgy. They're fat or morbidly fat. And there's no question that this disorder, which goes on and recurs despite what you do for it, is related to lifestyle. And then these people, you have to sit down and talk to them about this whole concept of wellness and weight control and proper exercise and dietary restrictions and so forth. Maybe send them off to the nutritionist, the dietitian, I should say, to try to learn a little bit more about that. So if lifestyle seems to be impacting upon their disease, absolutely, you mentioned this.
Yeah.
But actually, like you say, Dr. View, that you approach speaking to patients on lifestyle, it's very difficult, and it's not just in dermatology, but it's so many things in our culture that different lifestyle choices that people make, things like smoking or excessive use of alcohol or poor dietary habits and that sort of thing. Often you bring up those subjects, even in a very subtle or kindly way. Patients get offended. It's like you're overstepping your bounds, even as a physician, to broach these subjects.
And it's one of the more difficult tasks that I have encountered is to know how to reassure in such a way that the patient will accept themselves, whatever they have, because the skin is a very important aspect of their life, because it shows. I mean, there are people with beautiful skin are so much more appreciated in terms of being admired, or it boosts their self-image. And people who are born with a certain skin condition that is not perfect has a tough time. What I'm trying to say is that maybe part of the reason people with skin problems have difficulties is the cultural aspect of over-emphasizing or focusing on youth and beauty, plastic surgery, and plastic superficial looks.
Well, we're a youth and beauty-oriented culture, there's no question. And who are our role models when we're youngsters? We look at the magazine covers and we see these svelte, beautiful young ladies who are adequately, beautifully made up and not a blemish in sight. And every girl aspires to look like that. And those that fall short of the mark can be overwhelmed by this. And it's not an easy task oftentimes to deal with these people and reassure them and try to use a trite phrase to let them know that beauty is only skin deep,
right,
and that what really counts is what goes on within and so forth. And it's the personality and how they react with their friends and family, their environment, that is truly important. That's easily said and not always easily done, however, but it is an important part, certainly, of any specialty in medicine, but in dermatology in particular, because the skin is an obvious and visible organ, and we would all love to have absolutely flawless and blemishless skin, but I'm sure if we look beneath the makeup of these young ladies who are on the covers of the magazines, we would find flaws beneath this wonderful makeup job.
Because what I'm trying to say is that the anguish of a patient with especially serious chronic skin conditions are more mental. It's not that they don't have pain, they don't have physical pain. Itching is probably a more common physical symptom, but it's a mental and emotional turmoil. I have seen teenagers with acne that are very, very unhappy, and that's not because of the way it hurt or it doesn't even. It's just the way it looks. It doesn't look good, and that makes them very unhappy.
Yeah, but it's easier, I think, for the individual to go ahead and seek treatment for that. I mean, theoretically, they're just as good a person whether they have disfiguring acne or not. But it's how, like you mentioned, how our culture, accepts them, and it's impossible from their standpoint to change the cultural acceptance of it. And the one thing they can do is to seek treatment and have it, treated. I firmly believe that the patients that come to dermatologists come now with a different mindset from when I first started, and I'm sure from when Dr. Bright first started in practice. It was strictly patients coming for disease. They had a problem and they were forced to come to deal with the problem. But now they come for disease, but they also come for desire. A desire to improve their looks or improve how they feel. And it is psychological. Bill Blass, the clothing designer, once said that a guy goes out and buys a new shirt and puts it on, and he looks better, and therefore he feels better.
Yeah.
And it's the same thing whether it's a shirt or the skin.
Yeah, it's a combination of things, because I believe very strongly that if you have done everything, you've exhausted the armamentarium of medical treatment, but if the person has some desire that is unmet or a psychological conflict, do you think that part of the treatment would be doing some counseling, or because reassuring is a very broad term, isn't it? You have to get to know the patient and how the style of communication agrees. How much of that type of I guess counseling do you do in the dermatology practice?
A lot.
I think a fair amount.
Okay.
And how often and to what degree really depends upon your reading of the patient and what that young woman or that young man is asking and desirous of obtaining from you. So I think it's a fair amount. The reassurance is constant.
Okay.
And Now, certainly it's not true in a self-limiting short-term disease. If somebody has a nasty allergic reaction on their skin, you know, in a couple of weeks, full well that's going to be gone.
Yeah.
Not much reassurance beyond, hey, you're going to look fine, is necessary. But when you're dealing with something that is chronic and ongoing, psoriasis on the face, which requires constant treatment, or severe acne, where you know it's going to be a long time getting it under control, even though with the medications we have available to us now, we do a pretty good job of getting them under control. And this is where reassurance has to be constant and ongoing and very positive and very upbeat over the long haul. Okay, one point that I'd like to make, and maybe this is heresy for me to speak it, but I think that in some sense the profession is contributing and playing a role in this desire towards perfection, because there's seldom now a newspaper or a magazine that you pick up where you don't see somebody who is into cosmetics, be it a dentist, a plastic surgeon, a dermatologist, who's not suggesting, come to me and you'll have perfectly capped teeth, your nose can be fixed, your breast can be augmented, and so forth. And they are contributing to this this allure of this unattainable Venus de Milo approach. And gosh, if you tune in, if you have cable television and you channel surf early in the morning or late in the evening, how many shows do you come across now selling some sort of product which is mystically and magically going to rejuvenate and cause a youthful appearance to appear? So it's somewhat of market-driven at the same time, and I have trouble with that. I have trouble with that.
Yeah.
But it's also patient, driven. Patients want to look their best, and if there's simple things they can do to look better, they'll do it.
But I don't like to see patients made to feel inferior because they're less than perfect.
And that's true too. But it's interesting, if you look at the field of plastic surgery, it's really called plastic and reconstructive surgery. And there's two groups of patients there. One is patients that come for plastic procedures like a facelift or breast augmentation or something like this, and they tend to be very finicky and picky. They want things to be just right. They're not easy to please. And the other category is reconstruction, like a child with a cleft lip, or someone who's had a large skin cancer, and you can improve their scar, or a woman with a breast removed where they have breast reconstruction. And that's a completely different category of people. Those people tend to be very grateful. And a lot of the things that we see as, at first glance as cosmetic, like fixing scars on the face, or in my field I do a lot of hair transplantation. Most of those people don't feel like they're getting something extra in life. They're just they're wanting to restore something that they've lost.
Yeah. We have a few minutes left. So you think that as a group of specialists, the dermatologists are a happy bunch more so than others?
I think by and large so. I think as a group most physicians are pleased with what they do. They're happy for their choice. Certainly there's a few that have said, gosh, if I had to do it all over again, I'd go into engineering and not become a doctor or become an architect and so forth. Always one of my real burning desire, I wanted to be a professional baseball player, but I was never good enough to do that. I think doctors in general are happy individuals. I think doctors in general are grumbling a lot now because of the changes in the way that we practice with managed care, and which results in a lot of inconvenience for the doctor and the patient, and there's a reduction of income, which certainly has an impact upon the doctor's attitude. But I think doctors by and large are pretty good people and reasonably happy people, and I think this is certainly true amongst dermatologists. One of the nice aspects of our life is it's somewhat regulated. You hear the old business, our patients never die, they never get well, they never call in the middle of the night. Your hours tend to be regular. Fully half of the residents now, or if not more, are women. And I think they go into this specialty because it allows them to do both things. They can be home and have a reasonable family life and raise kids, and at the same time they can be satisfied professionally. And I think up at Stanford now, amongst the residents, there's probably only 1 or 2 males amongst the perhaps dozen residents that they have. So would you say they're a happy bunch?
Yeah, I think so. And it's also a great variety of things you can do within dermatology. Like Ross said at the beginning, one of the reasons he was attracted to dermatology is that it has that aspect of medicine, like an internist, where you sit and listen to a problem and end up writing a prescription, or it has that aspect where you can work with your hands and do surgery, you know, treating skin cancers or whatever you decide to do. So it's great variation. You can sort of follow your interest, or if your interest changes over the years, you can develop new areas of interest.
Yeah. I'm glad that the dermatologists are happy, but I have to disagree with you about the other doctors. I have met many unhappy doctors, especially now. And there are some fields that are very difficult, you know, and obviously, you know, it's not within our scope of discussion to go into that now. But do you have any? What is the organized medicine in the field of dermatology? One of the final question I want to ask you is, I think as a group, physicians are individualists that are very difficult to unite. Now, you have been in medicine for a very long time. What are the suggestions you think the methods or the way you can achieve consensus among physicians?
Oh, that's an hour's worth of discussion right there.
Yeah.
I think that there's a variety of ways it can be done. Certainly the union movement in medicine is growing rather strongly. That's not my view. I have difficulty with that. I think that we cannot approach this thing from the standpoint of appearing and being self-serving.
Okay.
And I think that we have to always look upon it as the standpoint, we are patient advocates, and we have to look at it from the advocacy standpoint. What is best for the patient? Right out, I would say managed care in the long term is not necessarily in the best interest of the patient. It denies them the access that they need. It creates tremendous inconvenience in terms of early discharge from the hospital, the case in point being the babies and mothers being sent home within 12 hours of delivery and so forth. I'd need a whole bunch more time really to elaborate on this.
Well, it's obviously, you know, we need more time for that. So anyway, wrapping up this second segment of our show on the quality issue in dermatology, I would like to thank our speakers for spending time with us here tonight, and I personally have learned a lot, for which I'm grateful, and I'm very assured that it's maybe the aspect of not so serious consequences of a little delay in diagnosis is reassuring to me. So anyway, this is Dr. Vu. Our show is America's Healthcare Crisis. We have been talking about the field of dermatology. Thank you for watching. Good night.
Always be there when you feel lonesome and deep in despair. Do you need someone to dry up your tears? Do you need someone to always be near? Do you have someone to stay through the years? Let me be the one, now that I am here. Let me be the one to be there with you through the hail and snow, so our love will grow. Let me be the one in the morning sun or the pouring rain. Let me be the one, let me be the one to hold you tonight.